Hello everyone, my name is Dr. Namanatha, and today we will briefly discuss oral anticoagulants, including their mechanism of action and their clinical indications, followed by their advantages and disadvantages. So let's jump right into it. Now, as far as the categories of oral anticoagulants are concerned, we have got vitamin K antagonists, of which warfarin is the most commonly used agent. It's widely available and it's been there for decades, and it's quite well known. And then we've got factor 10A inhibitors, which include apixaban, edoxaban, and rivaroxaban. Again, these agents are now increasingly used. And finally, we have got direct thrombin inhibitors, which are also quite new, and they include dabigatran, which is oral, and argatroban and bivalirudin, which are parenteral. I've mentioned these two just for comparison. Now, direct thrombin inhibitors and factor 10A inhibitors, these are called as NOACs or DOACs, and NOACs being standing for novel oral anticoagulants, or a DOAC being for a direct oral anticoagulant. So the term is interchangeable, and it's used for both of them. Now let's take a look at the mechanism of action of these agents. We know we've got a number of clotting factors in the body, and they circulate in an inactive form. Some of them play a very key role, such as inactivated factor 10. Now, inactivated factor 10, when activated, it further activates clotting factors down the line. And once it is activated, it plays a key role in the clotting pathway. So this step, factor 10 to factor 10A, is actually quite central. And this is where some of the agents act. So these anti-10A agents, they inhibit the activated factor 10A. Whereas warfarin, we know, inhibits the synthesis of vitamin K dependent clotting factors, which are 2, 7, 9, and 10. So it inhibits their synthesis directly from the liver. Now, clotting pathway is activated by intrinsic and extrinsic pathway. Intrinsic pathway, we know, is activated by endothelial injury, and it involves factor 12, 11, 9, and 8. And activated factor 9A and 8A then in turn activate factor 10. Now, warfarin again plays a role here by inhibiting the synthesis of factor 9. And then we've got the extrinsic pathway, which involves factor 7 and tissue factor. It is initiated by tissue injury. And warfarin again inhibits the synthesis of factor 7, therefore it affects the extrinsic pathway as well. So once factor 10 is activated along with activated factor 5, it converts factor 2, which is a prothrombin, into thrombin, or activated factor 2. And factor 2 or thrombin then converts fibrinogen into fibrin, which then leads to the formation of an actual clot. Now, once again, warfarin plays its role here by inhibiting the synthesis of a factor 2 or prothrombin. Whereas direct thrombin inhibitors, they inhibit the activated factor 2 or thrombin directly. So after briefly covering the mechanism of action of various oral anticoagulants, let's quickly discuss some of the common indications. A deep venous thrombosis, pulmonary emboli, quite common indications for the use of oral anticoagulants. Obviously, in pulmonary emboli, if they are clinically stable, then you give them the oral agent. And atrial fibrillation is another indication, common indication, and so the way we approach atrial fibrillation is by calculating the CHA2DS2-VASc score, and also uh, uh, we calculate the patient's bleeding risk by using the Hasbled score, and whether we are dealing with um, permanent, persistent, or paroxysmal atrial fibrillation. If the risk of clotting is high, then we consider the use of anticoagulants. And finally, as a prophylaxis in surgery, after surgery, especially in hip and knee surgeries, oral anticoagulants have a role. For all these indications, what dose we have to give and what duration we need to consider. BNF provides quite detailed guidance, so I strongly recommend going through BNF before prescribing in one of these indications. Now let's consider the advantages of warfarin where it is superior. It's quite inexpensive and it's been available for decades now. And when we compare it to the DOACs, and then we clearly see that it's relatively cheap. One benefit of warfarin is that you can use in people who are undergoing dialysis or those whose eGFR is less than 15, where you can't really use the DOACs. Warfarin is indicated in a number of conditions where you can't use a DOAC, like a left ventricular thrombus or valvular atrial fibrillation, or in prostatic valves. In these conditions, we would consider warfarin and not the DOACs. Warfarin has got a longer half-life than DOAC, so if a person misses a dose or two, it does not significantly impair INR. And finally, it's easily reversible if a person's INR is supratherapeutic, and then vitamin K, fresh frozen plasma, these can be used to bring the INR back to normal. Now, some disadvantages of warfarin where the DOACs are clearly superior. Um, we use frequent monitoring, repeated checkings of INR when warfarin is given, especially in phases when it's started. Once the INR is more stable, then the frequency of checking INR can be reduced. but even then you require frequent monitoring. And drug interactions are very common. There are a large number of drug interactions with warfarin, so something to be aware of. Now, where DOACs are clearly superior to warfarin, um, you don't require any frequent monitoring, you don't require any specific blood tests with the daily use, and then there are fewer interactions with the DOACs. And some studies indicate a lesser bleeding risk when we use DOAC as compared to warfarin. Now, the disadvantages of DOACs, where warfarin is considered, um, obviously you have to adjust the dose of the DOAC according to the estimated GFR. When it's below a certain threshold, then you can't really give it. It has got a short half-life, so the patient should not be missing out on any doses. Otherwise, there is a risk of recurrence of the thromboembolism. And the indications are limited. There are a number of places where you can't really use the DOACs, like prostatic valves or left ventricular thrombus or a valvular atrial fibrillation, in which cases you would clearly need warfarin. And these agents are relatively expensive, especially the direct thrombin inhibitors when you compare them to warfarin. So there you go, guys. Thanks for watching. Please do like and subscribe, and yeah, share it as well. Thank you.